Peter, thank you very much indeed. Would you mind if we took Rachel's talk and then we addressed you both with the questions? It's a great pleasure to welcome Rachel Clough, who is a research worker at St Thomas's. There's actually been not a huge amount moving forwards apart from blood pressure control in type B dissection until stenting came along. But actually knowing who to stent, knowing who is going to rupture, knowing who are the good and the bad guys in all of this is very difficult. And Rachel's been doing research to try and open up that field, which I think is very exciting. So it's a great pleasure to ask her to speak.
Thank you, Chairman, ladies and gentlemen. So dissection is complex, dynamic, and patient-specific. And what you can see in this slide here is that even in one patient, as you move from proximal to distal, the dissection has different dimensions of the true and the false lumen. These were supposed to be movies, and they show different amounts of mobility of the flap, and there's also different amounts of thrombus deposition as you move from top to bottom. And if you look on the left of the slide, even in a single plane, you can see that the dissection moves in and out of the plane and takes almost a spiral conformation. Fortunately, the majority of patients which present with type B aortic dissection are uncomplicated, and it's normally around 75% in large series. But if we look at these patients over 5 years, we see that in some series, up to 50% of patients are dead. And the question is, should we just be stenting these patients early on? Well, endovascular repair has complications, quite serious complications, such as death, stroke, and paraplegia, as well as conversion of the dissection from type B to type A. Particularly in the chronic setting, there are high rates of continued perfusion of the false lumen requiring re-intervention, as well as aortic-related deaths despite stent graft treatment. So we've, as Chris said, have been trying to work out if there's a cohort of patients at high risk of aortic expansion who may benefit from early endovascular repair. When we first looked at the literature, fortunately, there is some level 1 evidence in the form of randomized controlled trials. On the top of the slide, you can see the ADSORB study, which is a study of acute uncomplicated dissection. And on the bottom, you can see the INSTEAD study, which is a study of chronic uncomplicated aortic dissection. I can take you through those two trials now. So ADSORB is a study of acute dissection, which is defined as less than 14 days after the initiating event. And it compared best medical therapy with best medical therapy and stent graft treatment. Patients were enrolled between 2008 and 2010 with a total of 61 patients included. They chose to use a primary composite endpoint, which is outlined on the slide. They found a 16% crossover from best medical therapy to best medical therapy and stent graft treatment. There were no cases of stroke or paraplegia, and they showed that in these patients, aortic remodeling was significantly greater in the endovascular group, which might be what you'd expect considering the flap is supposed to be more mobile in this cohort. When we look at mortality, there were no deaths at 30 days, and during follow-up up to 1 year, there was just 1 death in the best medical therapy and stent graft group. Now, so the INSTEAD study, this was a study of chronic uncomplicated aortic dissection, again comparing best medical therapy and stent graft treatment. And this was between 2002 and 2004, the enrollment period, and then the patients were followed for 2 years. In this study, the primary endpoint was all-cause mortality at 2 years, with secondary endpoints of aortic-related mortality, progressive aortic pathology, and aortic remodeling. They also had a 16% crossover from best medical therapy to best medical therapy and stent graft treatment, but at 2 years, they found there was no difference in all-cause mortality between the two groups. They then looked at freedom from aortic-related mortality at 2 years and again showed no difference in aortic-related death. And in the conclusion of this study, they said that medical management for chronic uncomplicated type B aortic dissection has excellent survival, although close surveillance is important. I think there were then a number of offline conversations where they then considered that the 2-year results may not have demonstrated the potential benefits of endovascular repair because aortic-related events occur later in the disease course. They therefore chose to extend the trial to 5 years of follow-up and called it the INSTEAD XL study. They employed some statistical methods called landmark analysis, which is shown at the top of the slide, and also more conventional Kaplan-Meier studies, which are shown at the bottom of the slide. So this shows all-cause mortality, and if you evaluate the data on the traditional Kaplan-Meier method, it shows no difference between the groups at 5 years. This slide is organised in the same way, and you can see that there is actually a difference in aortic-related mortality at 5 years when you compare optimum medical therapy and stent graft treatment. But one of the problems with this type of evidence is they are trials which are by definition population studies and therefore provide population-based solutions. And if you look more closely at the data, there are some individuals within the trial which have poor outcomes despite following the trial recommended treatment. For example, in some of the patients who undergo stent graft treatment, they have rupture in the thoracic aorta at the level of the stent graft. And so there is some increasing interest in advancing our understanding of this disease to try to develop patient-specific solutions. And so some of the other centres have first of all worked on looking at anatomical predictors, such as this group in South Korea, and they first of all looked at the initial false lumen diameter in the upper descending thoracic aorta. And they showed that if this was greater than or equal to 22 millimetres, these patients had a worse outcome with follow-up up to 9 years, although the numbers at that stage are quite small. This is a study from the IRAD, which is the International Registry of Acute Aortic Dissection, and they showed that an aortic diameter greater than 5.5 centimetres is related to an increased mortality. There's also interest in imaging biomarkers, so false lumen thrombosis, and this study in the New England Journal found that partial thrombosis of the false lumen is associated with the worst outcomes. They showed in multivariate analysis that this particular parameter has a hazard ratio of 2.69. And then Artur Evangelista was interested in the use of functional imaging to evaluate outcome, and using echo, he looked at the size of the entry tear and the position of the entry tear and showed that if the entry tear is greater than 10 millimetres and in the proximal descending thoracic aorta, these patients have the worst outcome. And then in our centre, we've been doing some work looking at developing advanced imaging to assess these patients. And so what I'm going to show you in the next few slides are some of the techniques that we've been using. So this is cine imaging, which can either be just a two-dimensional image or it can be in 3 dimensions over time, so 4 dimensions. And we can use this type of technique to be able to look at the mobility of the entry tear, the mobility of the flap as a way to determine how much aortic remodelling we may get after stent graft treatment. It's also possible to acquire 4-dimensional phase contrast images. So in this image, the colours are related to the velocity of the blood flow, where red is high velocity and blue is low velocity. We can also use these type of images to look for the position and the contribution of the entry tears to both true and the false lumen. So what you can see in the still image is the position of the entry tear marked by the large arrow to the left of the slide, with an entry tear going from the true lumen into the false lumen to the right of the slide, and then more distal to that, high velocity flow as the true lumen narrows and the intimal flap moves across. So this should be another movie which shows that as a dynamic. Sorry, they worked upstairs. It's also possible to quantify the flow in the true and false lumen, and what we find in the majority of patients is the volume of flow is greater in the true lumen compared to the false lumen, but the amount of flow in the false lumen is associated with the rate of aortic expansion. It may be possible to use this type of parameter in future for risk stratification of individual patients. It's also possible to look at flow patterns using MR techniques. So in this slide is a flow pattern called helicity, which is effectively the rate of rotation in degrees per second in a plane perpendicular to the predominant direction of flow. And what we found is the greater the rate of rotation, so the greater the helicity, the faster the rate of aortic expansion. And this again should be a movie showing you that, so sorry. It's also possible using MR to evaluate wall shear stress, and what we found is that the wall shear stress in the false lumen is greatest in the proximal descending thoracic aorta, as you can see on the bottom left of the slide. And previous studies looking at vascular remodelling have shown that wall shear stress, which has a large circumferential component, is related to the greatest rates of aneurysm formation. And what we found in our work is that in the false lumen, the circumferential component predominates over the axial component. It's also possible to measure relative pressure using MR data. So in this slide, the colours in the image are related to pressure rather than to velocity. MR, I think, has generally been recognised as having high resolution, and you can see in this slide that it's very easy to see exactly where the areas of false lumen thrombosis are, with the blood bright, the thrombus dark, and the outer wall bright again. And we try to evaluate how accurate current clinical protocols are assessing false lumen thrombosis, particularly as it's an important endpoint of the clinical trials we've talked about. And so on the left of the slide, you can see something called first pass MR, which is effectively what we use in the clinical setting. It's the same as what we use, the way that we acquire the CT data. And with MR, you can acquire delayed phase images using a blood pool contrast agent, where you can see the marked difference in contrast enhancement in the false lumen shown by the red arrow. And if we quantify the difference, we can say that current clinical protocols overestimate the volume of thrombosis by an average of 6 times. And this can be easily appreciated. So if you imagine you deliver a bolus of contrast and you're measuring the amount of contrast enhancement in the false lumen, which is shown where the red arrow is located, you can see that it makes a difference on when you acquire the images in relation to when the contrast is being given. And then in terms of planning our stent graft treatment, we normally try to make sure we have enough radial force by oversizing the device by between 10 and 20% relative to the native aorta, which it depends on the initial aortic diameter, but it's somewhere in the region of 2 to 3 millimeters. And you can see just visually that between systole and diastole, the aortic diameter changes by more than 2 to 3 millimeters. One of the problems, though, is that if you acquire images in a fixed plane, which is just shown by the red slice here, as you have breathing and cardiac motion, the aorta can move in and out of this slice. And this is quite nicely appreciated in a study by University College London, where they showed if you choose an anatomical plane versus a static plane, there's a 20% difference in the measurements of area change. So in conclusion, type B dissection is dynamic, complex, and patient-specific. The selection of uncomplicated patients who would benefit from early endovascular repair is still under investigation, and we hope that advanced imaging may provide patient-specific solutions to evaluate the risk of rupture and to guide endovascular treatment. Thank you for your attention.
Rachel, stay. Peter, could we ask you to come back? I'm sure there'll be lots of questions. I don't know. I mean, I know about your work, but can you translate this clinically yet? Can you say this acute dissect type B should go for TEVAR rather than medical treatment, or is it still a bit too theoretic and far from that?
So far we've done it in cohorts of around maximum 20 patients as a way to develop a method and to try to assess the potential usefulness. I think to be able to sort of risk stratify on a population basis, we have to have more patients. And so we've now developed a clinical MR service for aortic imaging, where we include these sequences as part of the clinical protocol, so we can use them prospectively to see how patients do in the longer term. So not yet, but almost.
Not yet. Do we have any questions for at the back? Whilst we're waiting for Andy, Peter, I'm desperate. Oh, I'm sorry, I missed Hezza there.
I want just to ask, and I'm not, I'm going backward. Like, the hybrid, what does it mean in Greek?
It means a monster.
Good, thank you.
Andy.
Question for Peter Taylor. Peter, what do you think should the interval be between superaortic debranching and subsequent stenting?
Good question. So we have always separated it by 2 or 3 days. So it's the same hospital admission, but my list was on a Thursday, the endo list was on a Monday, so we left them 3 or 4 days. If it's urgent, then you can do it under the same anesthetic. And that case I showed you, we didn't have a hybrid lab, so we had to move the patient from one to the other under the same general anesthetic. So if you have to do it, you can do it. But I quite like to separate it. It doesn't add that much to, because once you've done the bypass, some patients get quite a lot of hematoma surrounding it, so it does take a while for it to settle down. And you just want to make sure they're okay, and then we do the second procedure on an epidural. They can go home really within 48 hours after that.
Sorry, follow up. Do you think the interval makes any difference to paraplegia rates?
I think the paraplegia rate is probably related to the length of the stent and the other comorbidities. So that comes back to should you revascularize or not. And actually, I showed you there's very little evidence that it makes any benefit. In our TEVAR series, we found that revascularization of the left subclavian made a difference for stroke, but not paraplegia. But I think certainly if you have previous infrarenal repair, you should strongly consider it, or disease of the left subclavian, or disease of the hypogastrics. Sorry, there's a question right at the back.
Hi. I didn't get a chance to ask you in Houston, Rachel. Because of your MR dynamic, the pictures clearly show that whatever we imaging with the CT scan and monitoring year on year or 6 monthly, whatever, the whole thing is just a waste of time, isn't it, to some extent? we shown that in our CT scan, I think probably about 2 meetings ago in Liverpool. Our radiologist said there's at least around 20% of variation in the sizes, and every time we image these CT scan. I just wonder how we can come to right way of monitoring these aorta so that we won't overtreat them or we won't undertreat them.
Yes, I mean, I agree with you. The reproducibility is quite difficult, and I think a lot of the anatomical markers we use, so like we said, diameter, false lumen diameter, or false lumen thrombosis, a lot of those are kind of indirect markers for the underlying hemodynamics and biomechanics. Because what we're trying to do with the imaging work is be able to measure those directly rather than necessarily having them measured indirectly through like these other markers. And in terms of what you were saying about when we do the clinical imaging between like subsequent scans looking at false lumen thrombosis, for example, we did a small study looking at how reproducible it was, and it really isn't that reproducible. So you're right.
There was a very nice paper from Frank Veith, who got a whole group of people together and asked them to measure the aortic diameter on a series of CT scans. These are experienced radiologists and vascular surgeons, and the average difference was 5 millimeters, or 4 millimeters, sorry. So you've got to get 5 millimeters, which is not very much, before you know there's at least a 1 millimeter difference. And that fact seems to have escaped the common sense of people writing guidelines, because the latest set of guidelines says any increase more than 4 millimeters in an aorta over 3 months is important, but actually that's within the confines of the test. And I think too much reliance has been placed on minuscule changes. I think you've got to see a decent change.
The subclavian carotid bypass showed it that it makes no difference whether in regard to paraplegia. Do you think it's related to covering intercostal artery when you put a long segment?
Sure. And the incidence of paraplegia in dissection is probably less than it is in aneurysms. We're coming out with a paper in the European Journal which says there's no difference in pathology, but you think actually if you've occluded long-term all your intercostals, putting a stent there isn't going to make much difference. But if you, in the acute phase of an aortic dissection, all those intercostals are probably still being perfused. If you then cover them with a stent, then you may cause paraplegia. But we always go for the shortest stent, which will adequately cover the entry tear. So it's usually 2 centimeters proximal and 10 centimeters distally. So a 15 centimeter stent is probably the way to go. In chronic dissection, it's different.
There is, a fallacy that you put a stent or a graft in the upper half descending, somehow magically the abdominal aorta and the lower descending is not going to be aneurysmal. Well, the practice is not true.
Yes, you're right. So we did, this is where DeBakey classification I think is better. So DeBakey 3A is above the diaphragm, dissection finishes above the diaphragm. 3B, it goes on below and involves the visceral vessels. And when we looked at our long-term results for TVAR for chronic dissection, there was a big difference between those two. You can cure 85% of 3A, but you have big problems with further expansion and reintervention with 3B. So you're right. I hate to say it.
Thank you very much indeed, Peter and Rachel. I'm not sure how many times we've had vascular surgeons at the society meeting, but it's great to see an expansion that way. This officially ends this session, but we're moving seamlessly into the next session. But I suggest that whilst we change the faces at the front here, that perhaps you might want to stretch your legs and stand up and just have a move around, and we'll reconvene in 3 to 5 minutes.
very much.
Sorry.